What is on the horizon in the PrEP arena? Well, it's a full decade ago now that we learned that antiretroviral-based pre-exposure prophylaxis provides robust protection against HIV in all populations and routes of infection. And today, just over 1 million people have accessed PrEP. Our first generation of PrEP was daily and oral, consisting of tenofovir and emtricitabine, which are nucleotide reverse transcriptase inhibitors, in a single pill when taken daily as prescribed, and when adherence is high, we know that HIV protection is also consistent and high. We knew from previous studies that where HIV makes entry via the vaginal mucosa, then daily dosing is required. In contrast, when via the anal mucosa, then less than daily dosing is required. We have also more recently seen new antiretrovirals being used. Here you see daily and on-demand oral prevention with emtricitabine combined with tenofovir alafenamide, a nucleotide reverse transcriptase inhibitor. This can also be both daily and on-demand, but with better PK, this leads to fewer side effects and less antiviral required. So oral PrEP has definitely had an impact not only on individuals, but on the epidemic at large. In major cities where a combination of both oral PrEP and antiretrovirals as required have been used, we have seen significant reductions in incidence in communities. But daily oral PrEP isn't feasible for everyone. We know that users on their PrEP use journey have found that the need for daily use can be a barrier to early use, persistence, lead to PrEP pauses, and even discontinuation. And here in this description of PrEP users' journeys, you see a number of places where the need to take oral pills has undermined adherence to PrEP and therefore protection. We know that the challenge of adherence has been a factor for a number of different populations. And here you see a number of different studies that have reported this, particularly, and the example I show here is of the search study conducted in Uganda and Kenya, particularly young men and young women finding it difficult to adhere to PrEP on a daily basis. In this study from 083, you see again that some subpopulations struggle more than others, for example, those at younger ages. And in this group of studies amongst adolescents in young MSM and young adolescents in South Africa, we see that although adherence starts reasonably well, that ability to continue adherence beyond 3 to 6 to 9 months really becomes very difficult. We also know that there's a challenge of persistence with daily oral PrEP. Although a lot of enthusiasm at the start, and this is well illustrated in a study called Power from Africa, we see a significant fall off in PrEP usage beyond a month and certainly 3 months. And another study here from in transgender women and men who have sex with men, that up to 20% of participants were lost to follow-up or had stopped PrEP by month 6, citing in many cases negative partner reactions and stigmatizing healthcare services. Beyond the lack of persistence, I think we are also coming to understand that some of this is simply cycling on and off PrEP. So here in this study, between 37 and 62% of PrEP initiators discontinued at 6 months. This was also seen in the search study and very well described in the study by Sirota and others, showing young Black MSM in the US who had a complex pattern of PrEP starting and stopping, generally driven by a dislike of taking pills, side effect intolerability, and logistics around actually accessing PrEP. So there are both pros and cons to taking daily oral pills. The ability to stop and start obviously may be an advantage. It's good that some people can use on demand, and that PrEP can even be couriered. But the no's fall into the category of poor coverage due to lack of persistence and that struggle around daily adherence. Stockouts can also be a problem. So why is it that we as human beings struggle to stick to daily things? Well, motivation doesn't always translate into action, and there are behavioral biases which make it difficult for us to do things on a daily basis, particularly when we're young and busy. So overconfidence, myopia, loss aversion, status quo bias, all have been described as reasons why we may not, as humans, be able to do something on a daily basis. The solution, we think, in prevention may be less frequent and alternative dosing strategies. In other words, longer acting agents in different formulations. And that leads us to the second generation of PrEP. We learn lessons from psychiatry that both oral and long-acting injectable formulations of antipsychotics have made medications more amenable and more available to people with chronic psychiatric conditions. Here you see in this study, both adherence and persistence were improved with long-acting agents. We also learn lessons from reproductive health and the long-acting reversible contraceptives. So in this area of public health, we find that there are also adherence issues. 5% of unintended pregnancies occur amongst consistent contraceptive users, but 41% occur due to inconsistent use. And so we have seen that long-acting reversible contraceptives have become increasingly popular, particularly among younger populations. When looking at this particular study of long-acting reversible contraceptives with injectable hormonal therapy, as well in comparison with the pill, the patch, or the ring, you see again far better contraceptive success than shorter acting agents. And this was borne out even in younger populations. We conducted a study a couple of years ago now in adolescent young women, looking at a crossover study of injectables, oral contraceptives, and the Nuva ring, and asked users to think about this in the context of HIV prevention methodologies. And what you see is the reasons some people cited for not wanting to use oral contraceptive was the concern that they may not remember to take a daily pill. So that brings us to the second generation, and first in that is the vaginal ring. The Dapivirine Ring, it's a non-nucleoside reverse transcriptase inhibitor. It's used as a vaginal ring inserted monthly, and here you see two studies showing around about 30% vaccine efficacy in the randomized trials, but in the open label extension studies extending to a 50% efficacy. This has now been approved and is in the WHO recommendations for women in low and middle income countries as a second line to PrEP. So the topical rings again have pros and cons. We think there will be improved adherence, fewer side effects, the need potentially for fewer healthcare visits, but definitely young women, particularly in areas where vaginal products are not well known, need a period of acclimatization. We have great hope for the possibility of multi-purpose rings, but until that time, there are other considerations around sexual reproductive health that need to be borne in mind. The next wonderful discovery has occurred more recently, that being long-acting suspensions delivered via intramuscular injections. And here we consider cabotegravir long-acting. This is a strand transfer integrase inhibitor. And the two trials, HPTN-084 in young women and HPTN-083, have just finished in the last couple of years. The significant factor here is the long half-life of this intervention, with the injectable having a half-life of up to 65 days, and so requiring an injection only every 8 weeks. And certainly significant results we've seen here, most recently amongst the young women, showing a pooled HIV incidence in the whole population of just over 1 per 100 patient years, but a significant 83% reduction in HIV in women who were on the injectable arm. So without doubt, the injectables have a lot of promise. Again, the need for less frequent reminding, the ability to adhere. We do still need to understand how we will actually administer these drugs in practice. There are some considerations around the long tail. And again, we need to consider other aspects of sexual reproductive health along with this wonderful new intervention. There is another area of pre-exposure prophylaxis that is unfolding, namely that of passive immunization using broadly neutralizing antibodies. And the first agent to be investigated is this, VRC01. You see that it is a CD4 binding site monoclonal antibody. We've just completed a massive study known as the antibody-mediated prevention study, and this has just recently been published. In vitro viral susceptibility to VRC01 does appear to predict prevention efficacy in vivo. However, it was only effective against viruses measured to be neutralization sensitive. So in overall data, we did not see significant difference in HIV acquisition between the arms because only 30% of circulating strains in the control group were susceptible to in vivo to the antibody, giving us a lower power to detect overall efficacy. It is important, however, to note that this is a proof of concept, and happily there are many very exciting antibodies in the pipeline that will be put together into strategies to explore this further in the next few months and years to come. Moving along, in terms of what is up ahead of us, there is this agent known as Islatravir. It is a nucleoside reverse transcriptase translocation inhibitor, which has a novel mechanism of action. And this particular agent is being developed both for treatment and prevention in its first iteration as a monthly pill for HIV prevention. It's a very exciting PK, very potent, and the interim analysis suggests that monthly doses of Islatravir really does achieve very promising levels, suggesting that this may be a very effective preventive intervention. It is moving forward in clinical development, and here you see 2 phase 3 trials, Empower 022 among cisgender women and Empower 024 among men and transgender women who have sex with men. These studies are just about to start, and in fact, P022 has commenced in the United States. And there you see the schema with a 1-to-1 randomization. All individuals will receive some form of PrEP, either as the monthly pill or as daily FTC TDF. And you see that it is a double-blind, double-dummy approach. Here you see the P024 study design, and this will be in a 2-to-1 randomization and will get underway a little bit later this year. Very exciting. This is being developed as a long-acting implant for HIV prevention, and we saw the first results of this, and this was further described at the most recent conferences. Moving forward, as mentioned, as an implantable, which is reversible with removal. It is certainly long-acting, hoping to be at least 6 months to a year, and has the potential for multi-purpose technology. There are other PrEP implants also underway. Here you see a TAF implant for prevention, and this was described at the recent R4P study in macaques, showing a lot of promise, and a cabotegravir reservoir implant for prevention. Again, early results shown at the R4P conference. There are long-acting injectables also coming to us in clinical trials this year. Here is Lenacapavir. It is an HIV-1 capsid inhibitor and will require dosing every 6 months. So really very exciting to only have to take an injection twice a year. And here you see the PK data. The design for this is will evaluate not only Lenacapavir, but also FTAF in young women who have sex with men in South Africa and other countries in Eastern and Central Africa. There are 2 primary endpoints as mentioned, Lenacapavir versus background HIV and FTAF versus, again, background HIV rate. So exciting new designs and new ways forward. This will also be tested amongst cisgender men, transgender women, transgender men, and gender non-binary individuals in a number of countries later this year. And there again, you see the design for that study. So a very exciting time when we really do have an impressive lineup of not only daily, on-demand, but also long-acting PrEP agents, the less frequent and alternative dosage, opening a lot of different opportunities, hopefully improving adherence, requiring less frequent reminding, potentially fewer healthcare visits, and perhaps hope for more discretion. There is no doubt that PrEP, like so many aspects of prevention, very much depends on preference. And throughout even a single individual's life course, career changes, new relationships, travel, different PrEP options may be preferred under different circumstances. We know that humanity comes in many shapes and forms, and we believe that prevention should too. We also believe that PrEP should. And I think it's very exciting that we are at this time when we are able to offer many different forms and modalities of PrEP. This will also require many different delivery models and distribution points. And I believe the next few months to years, we will begin to really hone what PrEP differentiated service delivery really means. I think it is then that we may expect better coverage of all people and better coverage of all HIV exposures. And with that, I acknowledge a number of different people and thank you for your time.